BOAST guidelines. British Orthopaedic Association Standard of Trauma Guidelines. BOAST 1 regarding the fragility fractures. Number 1. Standard prevention, anti-resorptive therapy, and fall assessment are effective in reducing further fragility fractures and must be integral part of the fracture care. Number 2. Multidisciplinary care should be done. Patient who cannot bear weight, who may have hip fracture, should be offered MRI if AP and lateral view X-ray are negative. If MRI is not available within 24 hours or is contraindicated, consider CT. Number 4. Ensure analgesia is sufficient to allow movements. Number 5. Correct comorbidities immediately so that surgery is not delayed. Number 6. Hip fracture surgery on the day of or the day after admission on a planned trauma list. Number 7. Physiotherapy postoperatively once a day is mandatory. Number 8. Orthogeriatric or orthopedic ward-based fracture hip program that include orthogeriatric assessment, rapid optimization of fitness, early individual goal for multidisciplinary approach to recover the mobility and independence of the patient. Number 9. Assess patient risk of delirium and dementia by actively looking for cognitive impairment when the patient first present at the hip fracture and perform regular reassessments. Number 10. If hip fracture complicates or precipitates a terminal illness, a multidisciplinary team should still consider the role of surgery. Number 11. Treatment of and to avoid risk thromboembolism and pressure sores. Number 12. Verbal and printed form about treatment, care and rehabilitation. Number 13. Data should be submitted to National Hip Fracture Database to monitor its performance against national benchmarks and quality standards. BOAST 2. BOAST 2 guidelines are associated with BAS, British Association of Spine Surgeons, and this regarding the spinal clearance in trauma patients. Number 1. A protocol of protection of entire spine must be in place in all hospitals managing trauma. Number 2. Documentation of neurological status must be made in all risk patients or any signs of spinal cord injury mandates urgent scanning. Number 3. Examination of the whole spine should be documented. Number 4. If the patient remains unconscious, inaccessible or unreliable for clinical examination for more than 48 hours, radiological spinal clearance should be undertaken. Number 5. In cervical spine, the appropriate standard is thin slice 2 to 3 mm helical CT scan from the base of the skull to the T1 with both sagittal and coronary reconstruction, extending that the scan to T4, T5 overcomes the difficulty of imaging of the upper thoracic spine. Number 6. CT scan should be undertaken as a routine if there is a first CT scan brain in all head injury patients. Number 7. The remaining thoracic or lumbar spine may be adequately imaged by AP and lateral plane radiographs by sagittal and coronary formatted of helical CT scan of the chest, abdomen and pelvis as part of modern CT scan trauma series less than 5 mm slices. Number 8. Senior radiologist should give the opinion. Number 8. MRI is an urgent investigation of choice in spinal cord injuries. BOAST 3 guidelines. These are also accredited by British Trauma Society and British Association of Urological Surgery. BOAST 3. Pelvic and acetabular fracture management. Number 1. The early application of pelvic binder or cross sheet will aid resuscitation and facilitate laparotomy if required. It may be necessary to replace this with the external fixator if there is an enforced delay in transfer. Number 2. Urgent treatment must include FFPs, platelets, and blood. If there remains ongoing hemodynamic instability attributable to the pelvic injury, then the further treatment options are open pelvic packing and embolism, where there is expertise. Number 3. Early CT scan should be undertaken. Number 4. If high suspicion of genitourinary damage requires early contrast study, cystogram or CT plus urethroplasty, it should be done as soon as possible. Intraparietal bladder tears, bladder neck involvement, or penetrating bone fragments require open bladder repair. Extraparietal injuries can be managed by urethral drainage. These all demand urgent urological input. Number 5. Open pelvic fractures with wound to the groin, buttock, perineum, vagina, or rectum require urgent bladder drainage by cystostomy tube and bowel diversion by end colostomy with washout. These demands urgent senior general surgical and urological input. Any colostomy should be done in upper abdominal quadrant, remote from the site of pelvic injury. Number 6. Posterior urethral injuries identified by urethroplasty should be managed initially by open or ultrasound guided suprapubic catheterization. Subsequently, when necessary, definitive repair by delayed urethroplasty will be part of specialist care. Number 7. A definitive plan of pelvic reconstruction needs to be formulated and carried out by the specialist pelvic surgeon as soon as possible, ideally within 5 days. Image transfer to hospital specialized in pelvic surgery should occur within 24 hours. Patient follow-up should occur in specialist pelvic unit to ensure full advice is available for the pain, physical, urological, and sexual disabilities, which are common outcomes. For cerebral fractures, number 10, the neurovascular status before and after reduction must be documented. Scalp traction should be applied. Number 11. CT scan must be done for accessible fractures within 24 hours to exclude bony entrapment and assess hip congruency and the extent of the fracture. These images should be referred to expert accessible fracture reconstruction promptly to secure urgent transfer for surgery if required. Number 12. The accessible fractures, ideally within 5 days, should be reconstructed, but not later than 10 days. Chemical thromboprophylaxis should be done within 48 hours. Number 4. These are also accredited by BAPRAS, British Orthopaedic Association of Plastic, Reconstructive and Aesthetic Care. Number 4. Management of severe open lower limb fractures. Including patients are high energy open fractures, multifragmentary, comminuted, segmental fractures, fracture with bone loss, either from extrusion or after debridement, soft tissue injuries with skin loss, tension-free wound closure is not possible, degloving injury, injury to one or more major arteries, wound contamination with marine, agriculture or sewage material. BOAST 4. Number 1. IV antibiotics are administered as soon as possible, ideally within 3 hours of injury. Coamoxiclave 1.2 gram or cefuroxime 1.5 gram Q8 hourly are continued until wound debridement. If penicillin allergy, clindamycin 600 mg Q6 hourly should be given. Number 2. Vascular and neurological status of the limb is assessed systematically and repeated intervals, particularly after reduction of the fracture or the application of splint. Number 3. Vascular impairment required immediate surgery and restoration of the circulation using shunts, ideally within 3 to 4 hours, with a maximum acceptable delay of 6 hours of warm ischemia. Number 4. Compartment syndrome needs immediate surgery. For the calf, it is with 2 incisions. Number 5. Urgent surgery is done for open fractures heavily contaminated with marine, agriculture, and sewage matters. Number 6. A combined management with plastic surgeon and orthopedic surgeon is done and clearly documented. Number 7. Allow photography of a cross-contaminated wound, then coverage in saline soaked gauze and in impermeable film to prevent desiccation. Number 8. Knee and ankle in the limb fractures should be splinted. Number 9. Centers that cannot provide plastic or orthopedic surgical care for severe open tibial fractures have protocol in place to early transfer. Number 10. The primary surgical treatment, wound excision, fracture stabilization of severe open tibial fracture only take place in non-specialist center if the patient cannot be transferred safely. Number 11. The wound, soft tissue and bony excision is performed by senior plastic and orthopedic surgeons on scheduled trauma list within normal hours and within 24 hours of the injury unless there is marine, agriculture or sewage contamination. The 6 hours rule does not apply for solitary open fractures. Antibiotics should be continued for 72 hours or definitive wound closure, whichever is sooner. Number 12. The definitive skeletal or soft tissue reconstruction should not be taken in a single stage. Then vacuum dressing or antibiotic bead pouch is applied until definitive surgery. Number 13. Definitive skeletal stabilization and wound cover should be achieved within 72 hours and should not exceed 7 days. Vacuum dresses are not used for definitive wound management. The wound in open tibial fracture in children are treated as same as adults.